I guess you could say YouTube page, and a podcast. So what we want to start with today is an introduction to the profession and to our practice. So let's start at the very beginning. When did we start Marchese Sports Therapy? I could pretend like I'm talking to you.
Hey, that works, yeah.
So, Kyle, back before you were
Tell me
born.
about it, yeah.
What year were you born?
94.
Holy crap.
So, yeah.
So I was in chiropractic school in 1992. All right, so I graduated from Palmer College in 1996, which is I guess you could say the preeminent chiropractic college. Unfortunately, Kyle went to life. So, yeah, not a big deal. Yeah, it's all right. I mean, I'm sure you got a scholarship, right? Play hockey or something.
Yeah.
So I got out. I got my first job in Everett, Massachusetts. Worked for a great guy, Brian Leahy. Brian, you probably never listened to this, but how you doing? Did about 2.5 years in that. And then went to my own private practice in Melrose, Massachusetts. And it started off named Melrose Highlands Chiropractic, which I joke about it because I sometimes bring my old book. I've kept my first patient book, appointment book, and the first day we opened up, we had 6 patients. Within, I want to say, 2 months, the book was filled. I was incredibly lucky, incredibly blessed for the past 28 years. But that went through a transition into what is now today being called Marchese Sports Therapy. So it was about 1999 when it began. We had an idea because myself, my partner in the endeavor, we're both, let's just say we had some injuries, ranging back high school, pre-high school, college, all the way through, and we were receiving care from multiple modalities. I'm not going to pick on any one group of people: chiropractic, physical therapy, massage therapy, athletic trainers, pretty much everybody. And we saw a very glaring deficit in the healthcare pertaining to musculoskeletal injuries, which would later morph into neuromusculoskeletal injuries. Okay, stop laughing. Yeah. I could catch you out of the corner. I still got excellent peripheral vision, even though I'm very, very old.
I'm trying to catch you, yeah.
Yeah, I can see. So, as you see here, this has pretty much been a standard of our practice for a very long time. We wanted to incorporate actual hands-on, and we'll pan around at some point during our progress here. We'll pan around into the office. So we need tables, obviously. We need weight training equipment, because standardized rehabilitation just wasn't doing it. You know, I see all of the blogs and all of the Instagram posts and everything else. Everybody has these beautiful gyms now. In 1998, we had our first facility, which was basically a gym. Before it was, I guess you could say, commonplace to go ahead and do things like that. And when we started taking people into more of a strength and conditioning mode, as well as a lot of hands-on, which also wasn't really practiced at that point, and one-on-one therapeutic intervention, we were chiropractors, but we kind of brought forth a completely different training and therapeutic model to injuries. And to be honest with you, it just took off because people started seeing that instead of taking 6 months to a year to get over things, or even the infamous 4 to 6 weeks that most practitioners will tell you about, we were getting people better in 1 to 2 visits. 1 to 2 visits is great. 1 to 2 visits is excellent for the person who is coming in. 1 to 2 visits is horrible for the practitioner because you can't get any long-term care. We like to call it the neuro-orthopedic and kinesiological approach. The reason why we ended up putting the neuro portion into that was because we remembered, oh yeah, we're chiropractors. The first thing that we take care of is the central nervous system. But we had to find out, because we were told in school, how to take care of things from a central nervous system perspective. And from that central nervous system perspective, the only tool that we were really given was an adjustment, which is one way of accessing one set of mechanoreceptors and affecting the central nervous system. It's a great way. It's incredibly powerful, and we were very lucky to learn that. But there's so many other ways to do it. With patients that would come in and feel better in 1, 2, 3 visits, we would say to them, Okay, so why, for example, if you had a shoulder dislocation and it was non-traumatic, why did your left shoulder dislocate instead of your right shoulder? Because we have to get, here we are doing an origin story for a practice, but in reality we're doing an origin story for the techniques that we've adapted. So why would one shoulder dislocate and not the other shoulder? Why would your lower back blow out on the right-hand side and not on the left-hand side when you were doing a bilateral exercise? The idea of strength deficits just didn't cut it, because you would test somebody and they'd have great strength on both sides. So why would one side blow up more so than the other? So you had to start thinking about, okay, we've got a person here, 1, 2, 3 visits, they're feeling better. So not just from a clinical model, but also from a practice model.
Yeah.
You get people better fast, and they don't come back, you don't make a lot of money. So you have to think, all right, if I want to exist in this culture, I can either get a crap ton of patients always coming in, or we have to figure out a way to get them from getting injured in the first place, which is the true nature of preventative care. A lot of people, especially nowadays, will say, well, Kyle, you can't predict an injury. You can't tell me when someone's going to get hurt. But you kind of can. When you start looking at the neurological model, neuro-orthopedic kinesiological approach, you look at the neurological model, you can figure out side of deficiency with not just their strength, but people forgot the 4-letter word that nobody really talks about very often, which is tone.
Yeah.
It's 4 letters, right?
Last time I checked. Yeah.
So, T-O-N-E, tone. So what's the difference between strength and tone? So what we started doing was a lot of neurological evaluations for everybody, not just a person who would come in with a drop foot, or not just a person who would come in with a neurological disorder like Parkinson's or MS or anything like that. But we started doing it on every single patient that came in the door.
And every time they come in the door.
And every time they come in the door.
Exactly.
Absolutely. Because if you don't reevaluate a person every time they come in from a neurological perspective,
Exactly.
what happens?
Yeah. I mean, you're not going to fix anything.
No, you're going to keep missing things.
Exactly.
You're going to swing and miss and swing and miss and swing and miss. And it's great if you're a clinic that likes to refer back to the orthopedist, because orthopedists love that kind of thing, because they get more procedures, more surgeries, etc. The problem with it is that you still have to find out what caused that injury in the first place, which the whole idea of chiropractic is that's what kind of rang true for us as far as being chiropractors. So the origin of our practice was to look really, really in depth at the central nervous system and start doing a neurological evaluation and then linking it towards the orthopedic evaluation, because everybody does an orthopedic evaluation, right? So what's this one called?
What is that? Prayer sign?
No, prayer sign. We'll cover that in another episode. How about this
exactly.
one? What is, bring it around up.
Yeah.
Yep, turn it in. Yeah, don't let me push. What's that called?
We're testing the trap.
Supraspinatus press test.
I thought we were talking muscle testing here.
Andrew, can I get someone else in here?
Yeah.
I'm just shit.
So, yeah, no, it's
actually not. I just made that up.
Oh, okay. I was like, uh-oh, I thought we were...
No, it's totally made up. Point being that if I were to go ahead and then say, we have a test of his supraspinatus, hold there, and we press into that, and it's strong. And turn your head to the right side. Then we hold here again, and we push in there, and it's strong. Turn your head to the left side. We push again, and we lose it. Why? Why does that happen? And what happens if he's a hockey player, and he decides to go ahead and have a right-handed shot, turn his head to the left, and take a shot, and he injures his shoulder? So was it the fact that he turned his head to the left that injured him? Or does he just have a temporarily weak supraspinatus muscle that tested positively for strength every single time? So that's the difference between strength and tone and orthopedic evaluations. You got to correlate them. So if we look at his neurological makeup as far as our evaluation goes, and we correlate that then to his orthopedic and manual muscle testing, and then we look into the third factor of it, which is the kinesiological factor. So kinesiology, we have a K for kinesiology with a little square next to it. So the types of kinesiology, there's the obvious one, which is basically the study of movement. Okay, everybody knows that. You're going to go ahead and do a kinesiological evaluation on somebody. You want to see how they move. You want to see them do a lunge. You want to see them do a squat, a press, all these different methods. And then you want to evaluate them biomechanically, as well as neuromuscularly, as far as we're concerned. But then there's the other kinesiology that nobody really talks about, because it's not considered, you say, valid? Depending upon who's looking at it. If you look up things like applied kinesiology and clinical kinesiology, they'll probably yield Google results of being quackery, probably very high up on the quack watch. But what is wrong with muscle testing? Because that is basically what applied kinesiology and clinical kinesiology tell us. And that goes, the origin of muscle testing goes way back until, oh my God, Kendall and Kendall, which was written a heck of a long time ago by a couple of physical therapists. I think they had about 40 or so exercises or 40 or so muscle tests, which then went into applied kinesiology. And applied kinesiology then does a similar amount of muscle tests. And then that gets extrapolated by the obsessive-compulsive arm of chiropractic known as clinical kinesiology by a guy named Alan G. Beardall, who was, as far as I'm concerned, one of the most brilliant people around. He's obviously since passed, and his son has taken over his practice out in Oregon, but it's extrapolated into over 900 muscle tests, 900 separate assessments from a kinesiological perspective of how the central nervous system is functioning, not just from a perspective of strength, but tone. Okay, there's that tone word again. So, neuro, orthopedic, kinesiology squared. That's the approach we took into it. Now with the kinesiology, we also put in strength and conditioning, therapeutic exercise, vestibular exercise, all the different, I guess, eye movements, vibration plates. We have a couple of machines here that work with all the cognitive activity.
Soon to be an interactive metronome.
And soon to be hopefully interactive metronome. So all the different types of ways to exercise through the kinesiology methods, because it's all biomechanical movements. So we have the long story short here, because I know I'm babbling on a bit, is to say that the origin story of our practice is still evolving, because we haven't even talked about the origin story of the practice yet. All we did was kind of tell you about what we do, which is a rambling, right, Jess? So that's what we do. Now let's talk about why we do it. So my personal reason for going to chiropractic school is probably different from a lot of people's stories. I was a high school athlete, like most people, and then turned collegiate athlete. In high school, I had a very traumatic injury and pretty much derailed any type of a career that I wanted to have. Still went on to play in college, but never really panned out so much in college. Hours, physical therapy, strength and conditioning, everything. Mine was similar to what I had mentioned before, of dislocation of a shoulder. And it was, my case, it was a traumatic posterior shoulder dislocation, which I don't know if anybody's ever had that, but it's probably one of the more painful things that you'll have in your life. And looking back now upon it, it's easy, because now I can say, wow, what I would have done, I probably would have addressed, number one, the fact that something like that has a massive ability to plasticize pain within a person's central nervous system, and one of the largest predictors of future injury is previous injury, and not necessarily because of biomechanical fault, but also because of this little unconscious, subconscious, but we'll get to that later on in some of our other podcasts and some of our other videos. So I went all the way through college, had what I consider to be really good physical therapy, amazing orthopedists, one of them being what I consider one of my practice mentors, Dr. Arnold Scheller. Amazing guy. Actually, I went to work with him later on in my career with Pro Sports Orthopedics. And, just kept going and going. And then I was in my 5th year of school, finishing up after playing a couple of years of football. And I really didn't know what I wanted to do. And to be honest with you, I didn't want to stay in school where I was. I just had no major options other than stay there, take a grad assistantship, and get my master's in physical therapy. And that was it. And I thought, nothing against physical therapy, but I had been in physical therapy for the better part of, I'd say, 8 years. And couldn't lift my arm, couldn't feel my hand. Had a lot of pain pretty much every day, every night. Never really saw any changes with the therapy that I was getting. So a friend of mine called me, one of my friends from the old neighborhood in Malden, and he was in chiropractic school out in Iowa at the time. He said, "Why don't you just come to Palmer?" I said, "Well, I don't really know anything about chiropractic." He's like, "Oh, it's amazing. You're going to love it. It's great, blah, blah, blah. And you don't have to worry about your GREs." He goes, "You have a 3.5, and at the point, I think I had a 3.65. But it wasn't getting any medical schools with that kind of a cue." And I said, "Sure." So I applied. I got in, and I went to chiropractic school, and I had no clue what the heck chiropractic was. Never saw a chiropractor. Never knew what it was all about. Nothing. So a little bit of a unique approach, because most people go to chiropractic school because they're helped by a chiropractor, right?
Exactly.
Well, I went to school. I sat down. There was a guy with a BC High jacket on, and I went to Malden Catholic. And I looked over. I'm like, "Hey, BC High." He's like, "Oh, hey, where'd you go?" I said, "Malden Catholic." We sat down in our first class, ready to go, and it was philosophy. Writing notes, and I look over at him. He's talking about, you will be able to palpate a human hair through Gray's Anatomy, and how if Adolf Hitler was adjusted, there would have been no war. I look at the guy next to me. I go, "Mike, is it too late to get our money back?" He goes, "I think we're already in this." So I wanted to leave right off the bat, because you can talk philosophical all you want. I was a kind of a meat and potatoes guy at the time, but then I started understanding what he was talking about. There is a good philosophical arm of all of that. The guy who was doing that was a great future president of the school as well. But man, I was not happy that first day. But then all the good stuff came out. Anatomy 1, Anatomy 2, physiology, all that stuff came out. And then I was very happy. It was an amazing experience. I learned from what I consider some of the best people in chiropractic. 2 of them weren't even chiropractors. So I got to work in the sports medicine department, play a little hockey, which was great as well. Then got out. Took a while, passed my boards, started working. And then the other part of it that we said before, that I should have said this part first, started to practice in 1998. Here we are in 2024, going strong at the pad in Woburn, stopping cold tanning. So that's my backstory. So if you want to start a backstory, I know you went to I'm trying to remember what it was called. It's a safety school in Marietta, Georgia. Yeah. They still have accreditation?
Yes. They do have accreditation.
They do. Are they going to lose it again, or are they going to keep it this time?
Yeah, I sure hope they don't lose it again.
Because then we can take that to Florida when it's nailed out there.
No, I loved going to Life University. It was a nice little bubble. Lots of athletes going there. Lots of brilliant people. My professors, I feel like they gave us a very good hybrid of like a holistic approach, but also a pharmaceutical approach to things. Gave us plenty of options in either direction, but just to kind of go back to why I became a chiropractor. Growing up, never went to a chiropractor. It wasn't until I hurt my back really bad in a hockey game. I got hit backwards over the boards. Had a real bad back pain for probably the next 5 to 6 months. And when I went to my primary at the time, they felt it. They said, "Oh, your back's in spasm," and gave me muscle relaxers and painkillers. At the time, I didn't really like taking anything like that because I felt it made me feel weird, right? And so for the next 5, 6 months, I was a 16-year-old with back pain, which at the time I didn't know very many people my age that had been dealing with something like that. Exactly, yeah. And I don't know, 5, 6 months go by, nothing's really working. I continued playing hockey, football, played a little bit of lacrosse, and nothing was fixing it. And I'd heard that chiropractors are pretty good at back pain. And my high school coach at the time, Dr. Shaw, I decided to go see him. And the first thing that he did when I got into the office was help move me around a little bit. And he was like, hey, like, I don't really feel comfortable adjusting this. And he wanted me to get x-rays first. So then we got x-rays. And that was a day where I found that I had 2 stress fractures in my lumbar vertebrae. And at that point, they just kind of put me in a back brace for 2-3 months and kind of called it good. But looking back on it, it was kind of crazy to me that I had been to all these different doctors, the ortho, my primary, and the only thing they really did was give me a medication and just kind of tell me to go on with my day, right? So that's what kind of opened my eyes to how cool chiropractic could be, because chiropractors are known to be very good with pain, right? And they tend to address the symptom rather than just putting a Band-Aid on it, even though sometimes that Band-Aid can be good, right?
They're also excellent dancers.
No, for sure. For sure. But that was kind of the start of why I had even looked into chiropractic. It wasn't until I got into my undergraduate. I played high school hockey, and then I decided to play in college. But my very first week of college, I actually ended up getting 2 major concussions and not even knowing. And yeah, my concussion story kind of started there. I didn't really connect chiropractors with concussions at that point. It wasn't until the end of my undergraduate degree where I did my senior thesis on holistic ways of healing traumatic brain injury. And I had heard about Ted Carrick and how he had exactly, and how he had treated Sidney Crosby at my wonderful alma mater, Life University.
Must have been low rent.
Exactly. But it wasn't until I really thought about how, I mean, chiropractors, we are, in a way, like we're neurologists. The thing that we affect is the nervous system.
And it's constantly forgotten.
Exactly.
We're here to go ahead and address this.
And I know my school at least really talked about the subluxation model.
Yeah.
Which is true, but also what controls subluxation? The nervous system. Right?
Yeah. You can call it anything you want.
Exactly. And you can even go into tone and all. Yeah, tone is what's going to affect all that. But it wasn't until I really made that connection that I can help people and I can address their nervous system. And I can do it all through one thing that is chiropractic. I can talk about healthy living. I mean, in my opinion, true primary care is assessing function before injury or disease actually happens, right? And
prevention.
Yeah, prevention. Exactly.
Prevention. There's that word again.
Exactly.
That you supposedly you can't do. And there's no such thing as prevention.
And prevention, let's be honest, if you prevent something, a lot of times you can save a lot of money if you maintain beforehand, right? Mm-hmm. These surgeries and lifelong medications, a lot of times you're not truly addressing an issue, you're just kind of saying, well, this is your new normal, right?
For sure.
And that's what I think chiropractors, that's kind of our superpower, is we can address every aspect of the spine in one visit, but even going into insurance and all that other fun stuff, it takes time to really sit down and think through these things,
sure.
Right? And to truly create a change that the nervous system is going to hold on to and that's going to create a lasting impact in someone's life.
Yeah, that's what I mean about it. When we were talking about before, when we were trying to get people to come in after they've already felt better. The symptoms are gone. What caused the symptoms are still there. So you have to, and it's not just, forget the subluxation model. That would be like calling a brand new Chevy car a Monza. It was a Monza back in the 60s, right? I'm sure you can think of a better name for it now that we know exactly what it should be.
Mm-hmm.
You know, let's go ahead and do things for 2024, not 2004.
Exactly.
You know,
Yeah.
revise what we do and don't continue just because something like subluxation sounds good.
Mm-hmm.
That doesn't mean you always have to use it. I had a friend of mine that used to love taking the dictionary, and he would take a word out of it every day
Oh, yeah.
and try to use it in as many sentences as he possibly could, right? So, and he would always use it wrong, right?
Yeah.
So if I get a person that comes in here and they come in and they've got neck pain and we do the evaluation, we find out there is an orthopedic reason for it, there's a neurological reason for it, there's a kinesiological reason for it.
Yeah.
People are smart. People are savvy, right? If I sit there and say, well, show them a picture of their neck and say, you've got a subluxation right there, I'm just going to say it.
Yeah.
Don't be an asshole. Don't do things that are so simplistic, trying to take all of this information that patient wants to know. They want to have an explanation. They don't want someone to say to them, it's just a subluxation. Because that doesn't hold water in most people that went past like grade 3.
Well, and I mean, as I'm sure you've heard me say to my patients, I mean, the term doctor means to educate.
It is. It's an educator. A chiropractor just means to use hands.
Exactly.
That's it. So we're educating for sure. But you have to talk to the patient like they're educated, like they have an idea of what's going on. You can't just tell them that this magical unicorn that appeared into your neck, of which you can say there's proof of it. You can say there's proof of anything just by your definition of it. If you define something and you show that definition, but that doesn't have anything to do with causation. But they'll still I still hear chiropractors using subluxation all over the place. And it's fine. If you want to do that, you want to practice that way, go ahead. But don't make sure that you're not committing like an act that will go ahead and keep that person from seeking help from somebody else who's going to explain it to them and get them better.
Exactly.
And that's not just chiropractors, obviously. There's a whole lot of other professions out there that are doing it. But to bring it back around, that's what we decided something years ago to start doing with patients, because I'm sick of I was in a practice and I had the subluxation model. We show the rust on the pipes.
Exactly.
First, 3 times a week for the first 4 to 6 weeks for the acute intensive basic care and all that. We did the whole thing. And after a while, I just remember having a patient who came in there. It's an old Italian patient. His wife used to bring me the most amazing eggplant parmesan sandwiches and a picture of her daughter. Yeah. The sandwich, she likes to cook too. You like this sandwich? You want to meet my daughter? Like, no, I don't want to meet your daughter, but I'll take the sandwich. I remember him one time. I was seeing him primarily because it was my job to see him, and I was an employee at the time. But I knew what he had, and I knew that I wasn't going to be able to fix it. Now, maybe different with all the different tools and methods that we have. Seeing that guy would have been much different right now. But at the time, I didn't have the tools to correct it. And he goes, "You think you're going to be able to help me?" I said, I had to look around and make sure my boss wasn't around. I said, "I don't think I'm going to be able to help." He goes, "You know what? Thank you. Thank you, thank you." I said, "Anytime,
Yeah.
I'm just giving up money, no big deal." And he goes, "And you know what? Don't be like that guy." I go, "Who's that?" And he talked about my boss, who was a great guy anyways.
Yeah.
And he goes, "That guy, he's full of shit. You're not full of shit." Thanks. And he got up, never got another eggplant sandwich. Definitely did go on a date with a daughter, but never saw the guy again. But to this day, I still remember those first few years because there were so many times when that happened.
Exactly.
Were there some great times in that office? Absolutely. There's some great people getting amazing results. Sure, because the chiropractic adjustment is that powerful that it will work on people despite everything else that's going on.
Exactly.
Right? But another reason why we went to the neurological protocols when I started my own practice.
Totally.
I have an aunt, wonderful person, and she has MS, and her prognosis was not good. She had a very different presentation where it was mainly, I would have to say, mesencephalic and cerebellar lesions, which you can imagine what that poor woman was going through.
Mm-hmm.
Just couldn't stop, fix the gaze, eyes shaking like crazy. So, and I was out of school maybe not even a year. So I had some other techniques under my belt, thank goodness, because I went to Palmer instead of Life. So I could do a few extra things there.
We got plenty of techniques.
Yeah. So I started employing everything I could. And I was, to be honest, I was horrified of my uncle. He was a tough son of a gun. So when he said, fix your aunt, I said, all right, I'll do my best. Don't hurt me. So I brought her in there, started working with her. And I don't know what I did. But the following visit, when she came in later that week, she wasn't shaking. And I thought, I have to figure this out quick, because if I do something today that messes her up again and she comes in shaking the next time, I'm going to have to go back, put it back again. I thought there's got to be so much more to the central nervous system than just manipulation or just doing some vestibular exercises or what have you. There has to be so much more to it. And honestly, and this is going to sound crazy, the neurological evaluation and all that is amazing. But I find that the most important thing to changing the central nervous system is the hands-on. But the application of the hands-on based upon the kinesiological evaluation. I think that is more, as I've been doing this for so many years, that has been probably the most important addition. And it's funny because we all took, I don't know if you took AK in school or if you took CK in school or anything.
I went to the
went to the club?
Yeah.
It probably scares you off because it's all the weird kids. Right?
A lot of muscle testing.
A lot of muscle
things,
testing.
Yeah.
But then if you sit back and you think, like, why are they muscle testing? How do you muscle test? And what are the purposes of muscle testing?
Exactly.
Right? And then you figure out, I've done muscle testing in probably 4 or 5 different techniques that I've gotten some certifications in. And still the best one is still the CK. That's number one. But the insight that it gives you into the central nervous system in the CK evaluation, it gives you more insight into the central nervous system and how to go ahead and get people better as fast as it possibly can. And give them a chance. Mm-hmm. Because a lot of people that come in here have been everywhere already. And we have to find some way to go ahead and give them a chance. I guess that's one of the things we do here that I'm really proud of, is that a person will come in and they won't have hope because they've been to so many different places. Or they've had an ACL and they can't contract their quad, right? Or they've had a surgical procedure on their shoulder and they can't lift their arm. Or they've had cancer, God forbid, thyroid cancer, one of my good friends and patients, and go through a 15, 16-hour procedure that saves their life by some amazingly gifted thoracic surgeon. But they won't be able to lift an appendage. And they're told, well, you know what? It's better than dying. That's what they're told. And then when you have the ability, because you've basically been allowed to stand on the shoulders of giants, which is what we have. PJ Palmer, you can say what you want about Sid. You know, still a good guy, but I mean, Alan G. Beard, all these great chiropractors that came before us, right? Because we were allowed to stand on their shoulders and be able to do what they taught everybody to do, we can get that guy and get a phone call on a Saturday out of nowhere saying, yep, just want to let you know. He's very direct. Came down this morning into my kitchen and reached up and grabbed a glass and realized I just lifted my arm. Is it supposed to be this quick? I'm like, here we go, 3 visits again. 3 visits. Paralyzed arm to lifting up and grabbing a glass. So that's how powerful some of the techniques are that we do here. For the future of what we're going to do with our podcasting, and for the future of what we're going to be doing with our videos, we are going to interview people, because God forbid you don't want to listen to he and I talk for 40 minutes at a time about nothing more than rambling about this office and origin stories and neuro-orthopedic kinesiology, etc. But we are going to get some guests on here in the future. We're also going to go ahead and start posting on our YouTube page. And I'm trying to remember what that, it's Marchese Sports Therapy is the YouTube page. So if you go on the YouTube, because I'm over 50, I can say that. YouTube, yeah. And you look it up, we'll be putting some great info on there as to everything from neurological evaluations, orthopedic evaluations, kinesiological evaluations, our methodology as far as how we link it all together. Of course, we're not going to give it all away, because someone had made a great statement this morning regarding going to chiropractic school or going to physical therapy school. And the physical therapist, when they did their interning, said, oh, you should definitely be a chiropractor. And the chiropractor, when they did their internship, said, oh, you should definitely be a physical therapist. So what we do here is pretty much a mashup of PT, OT, massage therapy, athletic training, chiropractic, and neurology and personal training. So we're going to start teaching our methodologies starting probably in the spring with our first module on the neuro-orthopedic kinesiological evaluation and treatment protocol. And we're going to start teaching it so we can all just get along. So you don't have to say, I want to be a physical therapist, or I want to be a chiropractor, or an athletic trainer, personal trainer, whatever. We'll be able to teach what we do to all professions, as long as you have a license. But so as long as we have a license, we'll be teaching that as well, and then we'll be linking our podcast, and we'll be linking our YouTube page, and we'll be linking our lecture series all together into one place. How we're going to do that when Jesse intern's internship is over, I have no idea yet because I'm a bit of a Luddite, so bear with us if we do have some production issues. But I'm sure by then you'll have it figured out.
Exactly, yeah.
Andrew will have it figured out, who works with us. Liz will have it figured out. The whole staff will have it figured out. Or maybe we'll just hire Jess when she graduates.
Yeah.
That would probably be a better idea.
Yeah.
Do you have any parting words?
No, not really. I mean, I look forward to going over some patient case studies and kind of getting any kind of feedback from you guys out there watching this. It would be very beneficial.
Do you have anywhere on social media that you want people to follow you?
Yeah. Marchese Sports Therapy. And I'm about to... I have an Instagram. I haven't really filled it out, but it's Doc Trescott DC on Instagram.
Okay.
So
and I think ours is Marchese Sports Therapy. Right?
I believe so, yes.
Then we have a second one that is New England Neuro Sports Therapy.
And that's Neurosports.
Neurosports. Did I just say that?
Neuro.
Neuro? You're going to make fun of my...
The Boston, yeah.
What is it when you can't talk? So you can find us on Instagram, and if you're over 70, you can find us on Facebook. On our YouTube page as well, Marchese Sports Therapy, Marchese Sports Therapy, Marchese Sports Therapy, and LinkedIn.
Yeah.
I think we're on LinkedIn as well.
Yeah, definitely on LinkedIn.
So we've got all the social media going.
Of course.
Yeah, and we'll try to get this podcast and video series going.
Well, that was fun.
That was a blast. All right, let's try to do this once every few weeks, or every couple of weeks, or maybe we'll do it once a week.
Yeah.
Who knows? Depends. We've got a lot of people we want to get on here. It's going to be an awful lot of fun.
Exactly.
I don't know who our first guest is going to be, but I have a really good idea, and it'll be very interesting. And we'll both be. It might involve hockey and healthcare. So
yeah. Hey.
we'll see, or it might just involve healthcare